Good morning, everybody, and thank you for joining us. Today, we are implementing our Health to Hold, our monthly community resource webinar series. My name is Jenna Sistad, and I'm with the Ocean Monmouth Health Alliance, which is our region's cancer and chronic disease prevention coalition. We are joined by many partners monthly to discuss the importance of our Health Awareness Month. And this month, we have our Breast and Liver Cancer Awareness Month. And we have our partners here at Memorial Sloan Kettering to take us through some talking about what they do on a regular basis at their facilities and doing some education for us. So thank you so much for being here. Dr. Wong, I understand you're going to be first on the panel, so thanks for being here. I'm going to toss it to you.
Thank you. Okay, can you advance the slide? Perfect. So good morning, everyone, and thank you for the opportunity to speak to you all a little bit today about who we are and what we do. My name is Serena Wong. I'm a medical oncologist. My specialty is breast cancer, and I am also the medical site director at MSK Monmouth. Next slide. So for those of you who may not be familiar with Memorial Sloan Kettering, we are a large cancer treatment and research institution, and our singular mission is ending cancer for life. There are multiple facets to what we do. We conduct groundbreaking research both in the laboratory as well as in the clinic, with the hope to further our knowledge and treatments for cancer. We provide education to both the public as well as the medical community. And of course, at the core of what we do is provide compassionate and exceptional care to all of our patients along the entire cancer care continuum. Next. We have a number of different sites. Our main campus is located in Manhattan. That's where we have a large inpatient hospital, many research labs, as well as many outpatient offices. But of course, we do realize the importance of being able to get high quality care closer to home. And so we built a large network of outpatient facilities in both New York and New Jersey. As you can see, we have a few sites on Long Island, we have one in Westchester, and then 3 sites in New Jersey. In New Jersey, we have our Bergen site that's located in Montvale. We have a second site in Basking Ridge. And last but not least, we have our site at Monmouth, which is our largest of all the sites in the care network. And that's where I'm located. I'm going to talk to you a little bit about that today. Next. So we're located in Middletown on Red Hill Road. We are just off exit 114 in the Parkway. And our goal is really to provide our patients with a one-stop shopping, convenient place where they can receive all of their cancer care. So at our site, we have teams of surgeons, medical oncologists, and radiation oncologists who all practice together in the same location with the idea that our patients don't need to travel to different offices to be able to see the different members of their care team. We have over 65 physician and nurse practitioner practices at Monmouth. We are the only regional care site to have operating rooms. We do perform same-day surgeries. For the more complex surgeries, higher risk, and those that require an overnight stay, those are still done at the main campus in Manhattan. We have 37 private chemotherapy infusion rooms where patients can come with their families and receive their treatment in a very nice environment. We have 4 linear accelerators. These are machines that deliver radiation to our patients. And we offer a whole array of radiology modalities, such as PET scans, CT scans, MRIs, breast imaging. We also have an interventional radiology program. These are radiologists who perform image-guided procedures, so for example, biopsies or catheter placements. Next. Now, of course, we know that comprehensive cancer treatment involves more than just delivering the cancer therapies themselves, and we recognize the importance of having multiple support services that are really essential to ensuring that each of our patients has the best experience possible. In the interest of time, I'm not going to go through every point on this slide, but just to point out a few of the services that we offer to help support our patients, we have pain management specialists, mental health providers to offer psychosocial support, nutritional counseling, just to name a few. Importantly, we also offer a number of clinical trials for our cancer patients. Clinical trials provide access to what we believe to be promising new cancer therapies that are not usually available to the general oncology community. Next. I'm going to briefly mention a couple of cancer screening programs we have at our site. Next slide. The first is our breast cancer screening program. We offer routine screening mammograms. You do not have to be an MSK patient to get your mammogram at MSK. If your provider provides you with a prescription for a screening mammogram, that can be faxed to this number that's indicated on the screen, and then you can call this number to schedule an appointment. We also offer something called second opinion imaging review. So if someone has an abnormal mammogram that was done on the outside and you'd like one of our radiologists to render an opinion, that can certainly be done. And if a biopsy is recommended, we can also set that up at our site. We have something called the RISE program. This is for high-risk individuals, so patients who are deemed to be at high risk of developing breast cancer for a number of different factors, such as a family's history of breast cancer. In this program, the practitioner comes up with an individualized surveillance program. For example, that might include mammograms alternating with MRIs. They'll also discuss prevention and risk reduction options. And this is the number on the screen to call if you'd like a consultation. Next slide. We also have a lung cancer screening program. This entails low-dose CT scans for individuals who are at high risk for lung cancer. Those would be individuals meeting the following criteria. So being a current smoker, or if you quit smoking within the last 15 years, you're between the ages of 15 and 80, and have smoked at least 1 pack per day for at least 20 years, or the equivalent, such as 2 packs per day for 10 years. This is the number to call for more information on that program. Next. So I've kind of given you a whirlwind of what we offer at MSK. We actually have a lot more, but in the interest of time, I'm not going to go through everything. But feel free to visit our website. That's mskcc.org. If you would like to schedule an appointment at MSK, please feel free to call this number. There's someone available 24/7 to answer your call. If you are a healthcare provider and you'd like to refer a patient, there's a special email box, refer a patient at mskcc.org, or you can call the clinician access line at the number listed here. We get asked frequently if telemedicine appointments are available, and the answer is yes. They're available upon request for first appointments, second opinions, or follow-up appointments. You would just mention that to the care advisor. And with that, I'm going to pass the baton over to my colleague, Dr. Kristen Bellin. She is a breast radiologist at MSK Monmouth, and she's going to talk a little bit about breast cancer screening. Thank you.
Hi there, my name is Kristen Belen. I am a breast radiologist, and my specialty is doing breast screenings and interventions. Next slide, please. Why is breast cancer screening important? Breast cancer is the most common cancer diagnosed among women in the United States. 1 in 8 women will be diagnosed with breast cancer over the course of their lifetimes. It's a big number. And it's the second leading cause of death from cancer in women, second only to lung cancer. Next slide. To the left is a picture of one of my colleagues, Dr. Molly Hogan, who you may meet if you come in to see us. The goal of breast cancer screening is to detect detect cancers early when they're very small and most easily treated. Approximately 75% of women who are diagnosed with breast cancers have no identifiable risk factors, which I'll get into later on. And mammography remains the gold standard of breast cancer screening, although we have other modalities at our service, such as ultrasound and MRI. Mammography is the only modality with proven mortality benefit, meaning the ability to decrease the number of cancer deaths due to breast cancer. In fact, according to the National Cancer Institute, In the United States, breast cancer death rate has decreased by 30% since its widespread implementation in the 1990s. Next slide, please. Next slide. Thank you. What are the risks of screening mammography? A lot of women come in and say that getting a mammogram makes them very anxious, so anxiety. This is usually very short term. It comes in terms of what to expect when they're getting a mammogram, if it's going to hurt when they get a mammogram. One of the things that can decrease the pain associated with a mammogram is if you know when your period is, schedule it either the week after your period, but not the week before or during your period, because your breast can be the most sensitive at that time. Some people have anxiety regarding the results. So there are things called false positives, meaning that you may be called back from your screening mammogram to do some additional imaging, such as ultrasound or additional mammogram images, which can lead to biopsies. A biopsy is a tissue sample of the breast tissue to find out if what we're seeing is a cancer or another process that's happening inside the breast tissue. One of the questions I get asked a lot is, what about the concern about radiation during a mammogram? The actual amount of radiation during a mammogram is quite small. It's about the same amount of radiation of normal environmental background radiation in a 7-week period, just for normal daily activities. Some people equate it to the same amount of radiation as an overseas round trip flight or a week in a high altitude location such as Denver. So very small. Next slide, please. Actually, go back one slide, please. In terms of the false positive and the recall rate, I will tell you that it's very common to be called back from a screening mammogram. About 10% of women are called back from screening mammograms, and of those 10%, 10 of those, excuse me, 6 of the women will do some additional imaging and they'll go back to normal screening once a year. 2 of those women will be called back in 6 months for a follow-up examination, and 2 of those women will undergo a biopsy. Of those biopsies, approximately 1 in 100 end up being a cancer. Next slide, please. What are the risk factors for breast cancer? There are several risk factors, many of which we can't control, like older age. The older we are, the more likely we are to be diagnosed with breast cancer, family history of breast cancer or ovarian cancer, older age in menopause, younger age when we start our period, never having born children, obesity, history of chest radiation under 30 for things like lymphoma or other diseases, dense breast tissue, which 50% of women have. It's a normal thing to have dense breast tissue, or certain history of high-risk lesions on breast biopsy. Next slide, please. I just want to take a quick moment to speak about race and ethnicity in breast cancer. In women under 40, breast cancer is more common in African American women compared to white women. And risk in different groups varies by type of cancer. For example, African American women are more likely to be diagnosed with triple negative breast cancer as opposed to other types of breast cancer. And certain ethnic minorities, such as Black and Jewish women, may have more likely have genetic mutations associated with breast cancer and or develop more aggressive breast cancers. Next slide, please. So how do you know if you're high risk? There are certain types of exams that we can do, where we ask you questions about your personal history, your family history, do a genetic evaluation, and women who have a cumulative lifetime risk of over 20% are considered high risk. And what we do for these women is that they may benefit from additional cancer screening at a younger age or supplemental screening, such as a yearly breast MRI, in addition to their screening mammogram. Next slide, please. One of the things that Dr. Wong alluded to is that we have a RISE program at MSK. It's called the Risk Assessment, Imaging, and Surveillance and Education Program, and it provides an individual assessment based on personal history, family history, genetic information. And based on that information, you get a tailored screening and ongoing evaluation, ongoing follow-up based on what your assessment shows. Additionally, to provide additional counseling on chemoprevention and risk-reducing surgeries. The picture on the left is Joanne Craig, who runs the RISE program at Memorial Sloan Kettering at our Monmouth location. Next slide, please. We have many breast cancer screenings options at Memorial Sloan Kettering and at Monmouth. We do mammography with tomosynthesis, which is commonly known as 3D imaging, which helps us get a better sense of what's going on inside the breast tissue, especially in women with dense breasts. It can show us more information than a traditional 2D mammogram. We do breast ultrasound, which does not have radiation. We use sound waves to further identify imaging findings in the breast. We do magnetic resonance imaging, MRI, which is magnets, again, not radiation. And we do also something called contrast enhanced mammography, which is using IV contrast, which is similar to an MRI to help us show if there's any abnormality inside the breast that needs additional workup. It's helpful for women who are claustrophobic or have things like pacemakers, which would not allow them to go into an MRI machine. Next slide, please. So the take-home points about breast cancer screening that I want you to remember is that screening mammograms for normal risk women should begin at the age of 40. Many studies have shown that women starting at age 40 get the most benefit from screening, and they have the most life years saved for younger women. Annual screening mammograms save the most life by detecting cancers when they're small and most amenable to treatment. And supplemental screening is available for women at high risk who have a greater than 20% cumulative lifetime risk that I spoke about earlier. And MSK Monmouth has all of these things available to you. So you can come by even if you're not an MSK patient. We're happy to see you and we're happy to take care of you. Next, and I'm going to pass on to Sue Park, who is one of our medical oncologists.
Hi, everyone. I am Sue Park. I am one of the breast medicine oncologists, and I practice out of the MSK Monmouth location. And I'll be talking a little bit about some of the basics of breast cancer, and the goal is just to give you a little bit of an overview. Next slide. So October is Breast Cancer Awareness Month, and I think it's pretty fitting to talk about. Breast cancer is globally the most common cancer, as well as in the US. And in the United States, over 310,000 women are diagnosed with breast cancer a year. And it is the second most common cause of cancer-related death in the US, second only to lung cancer. Next slide. One of the interesting trends is that, over the years, breast cancer incidence has continued to increase, while mortality has thankfully decreased. This is largely attributed to the implementation of nationwide screening initiatives, leading to earlier diagnosis and the improvement of a lot of treatments that we have in the modern day. Next slide. This is a slide of a number of risk factors. I think Dr. Kristen Boleyn kind of went through a lot of this already. Overall, I just wanted to highlight some of the key risk factors and just kind of say a few points additionally. So overall, the kind of single largest risk factor for breast cancer is just being a woman. A lot of times people want to know why they have breast cancer. They say, I did everything correct. I didn't do any vices. I lead a healthy, good life. Why is this happening to me? And the answer is simply the fact that it is the most common cancer in women. And just being a woman alone increases your risk by about 100-fold compared to being a man. Increasing age is another very major risk factor. The probability of a woman developing breast cancer by age 49 is about 2.1%. And it just progressively gets higher as you get older. So by death or kind of within your lifetime, a woman has a chance of developing breast cancer about 12.9%, which is about 1 in 8 chance. Okay. Having had breast cancer or having a first-degree relative, so like parents, siblings, children, etc., with breast or ovarian cancer, even if it was an in situ breast cancer, is a major risk factor for breast cancer. For example, just having one first-degree family member, with in situ or invasive cancer doubles your risk of breast cancer, and having 2 first-degree relatives kind of increases your risk kind of exponentially from there.
A lot of times we see women who are very concerned about genetic testing and whether they inherited something that they may pass on to other family members. And even though we see this correlation with family members and your personal risk of breast cancer, the truth is the majority of people do not actually have an inherited mutation. For example, BRCA1 and BRCA2 are found in less than 10%, probably closer to about 6% of people that we test. Next slide. So what can you do to decrease your risk of breast cancer? So there are a lot of things that are not in our control, but there are some things that we have some level of confidence that it has some protective measures in terms of breast cancer risk. So exercise is one of the most important things that you can do to decrease your risk. The precise type of exercise and the amount of exercise is a little less clear. What is clear that any exercise has benefit over none. So just getting up and moving is something that is helpful. Both light intensity and high intensity physical activity was associated with benefit. And in general, more exercise is better than less, but even low intensity is better than none. In general, we try to recommend people to strive for at least 100 hours of cardiovascular exercise a week as a general kind of goal. One of the risk factors for developing breast cancer is obesity. It's in postmenopausal women. So after menopause, adipose tissue or fat cells is where a lot of estrogen is produced. Therefore, weight loss after menopause is something that has been shown to kind of modify that risk to some degree. There's been some studies that have shown kind of various amounts of benefit, but different studies have shown somewhere around 10 kilograms or about 20 pounds of weight loss has been associated with a lower risk of breast cancer. So something that kind of goes hand in hand with increasing exercise is usually weight loss. Alcohol is something that has been shown to kind of modestly increase the risk of breast cancer. And this includes both low consumption and high consumption. So anywhere from like 1 drink a day to like more than 3 drinks a day when you compare them to non-drinkers. One study showed that for every 10-gram increase in daily alcohol intake, and 10 grams is kind of the equivalent of 1 standard drink. So kind of like a standard wine or glass, like a glass of wine or beer or like a standard kind of cocktail serving. Increase the relative risk of breast cancer. The relative risk of breast cancer was increased just slightly. Therefore, eliminating or minimizing alcohol consumption altogether can have some modest decrease in your risk of breast cancer. The impact of diet is really less clear. So diet is an area where, compared to the other factors on this list, there's a lot less kind of concrete evidence that to say what kind of diet is helpful. But in general, what's believed is that, what is healthy for people, so generally what's believed as a healthy diet, is going to also be beneficial for breast cancer risk reduction. So this includes things like having a diet that is low fat, low in red meat, low in processed food, high in fruits and vegetables and fiber, and kind of that Mediterranean diet that's touted for kind of a lot of other health benefit is generally thought to be healthy for breast cancer risk as well. Okay, and go on to the next slide. So staging of breast cancer relates to, how much did the breast cancer involve and to what extent did it spread? So stage 1 is the kind of first picture here on the very left, and it's relating to small breast cancers that are still confined with the breast, within the breast. Stage 2 cancers, which is the next photo over, relates to tumors that are larger, that are confined in the breast, or that are starting to involve some lymph nodes. Stage 3, the far right photo in the picture, are cancers that are more locally advanced. So they're including the breast and kind of more extensive regional lymph node involvement. Stage 4, which is commonly referred to as a metastatic cancer, means that cancer cells have been found outside of the regional area, so outside of the breast and the lymph nodes. This usually means that cancer cells had to have escaped and traveled farther into the bloodstream to get to places like the bone or liver or lungs. Okay, next slide. Sorry, next slide. Okay. So majority of, thankfully, the staging is important because the staging relates to prognosis and what you would expect in terms of how well people to do. Thankfully, the majority of people that are diagnosed with breast cancer are diagnosed at a very early stage. So 2/3 of people are kind of diagnosed, kind of localized, like kind of confined within the breast. And if you include, people that are kind of in the breast or even including the lymph nodes, that's nearly like 90% of patients. So the people that are diagnosed at more advanced stage and are metastatic are a much smaller percentage. And as you can see, people that are diagnosed, with it still confined in the breast have a 5-year survival rate that is nearly 100. So people can do quite well. Next slide. So how is early breast cancer, so cancer that is not metastatic, treated? We're going to focus on I'm going to focus on early stage because I think metastatic cancer is kind of outside of the scope of the talk. Next slide. Okay, so so early stage breast cancer treatment is really divided up into local therapies and systemic therapies. Local therapy is focused on the breast, and the systemic therapy is kind of focused on the rest. So making sure that the whole body is being treated. So in terms of local therapy, this really kind of centers around surgery, which can include various different surgeries of the breast, as well as the lymph nodes, and radiation therapy. The systemic therapy can vary depending on the type of breast cancer that you have, but these things can include things like hormonal therapy, chemotherapy, biologic or targeted therapy, and immunotherapy. Next. So in terms of surgery, mastectomy refers to removing all of the breast tissue. So kind of this picture here on the far left. And lumpectomy is otherwise known as breast conservation surgery. It's exactly what it sounds like. The goal is to try to preserve or conserve the breast and just remove the tumor only. So in this type of surgery, instead of removing all of the breast tissue, you remove just the tumor and a little bit of the surrounding tissue, just enough to get kind of clear margins, with the goal of keeping the breast as preserved as possible. In the past, mastectomies were more commonly used, and these could even be very morbid surgeries, involving not just the breast, but additional muscle and kind of additional tissues. But this type of surgery has evolved over the years, thankfully, to become a much less morbid type of surgery. In general, different depending on the case, not everyone may be a candidate for lumpectomy, but the majority will be. And in most cases, if breast conservation is an option, that usually is a preferred treatment type. In cases where they're both offered, a lot of studies have actually shown that long-term survival and breast cancer outcomes are very comparable between a mastectomy and breast conservation. Okay, next slide. So radiation therapy is often coupled with surgery to obtain local control. So radiation therapy uses high energy beams to destroy any microscopic cancer cells that may still remain in the breast and local area after surgery. And this is to reduce the risk of any local recurrence. Radiation is usually given after lumpectomy, and it is only sometimes given after mastectomy, so it kind of depends on the case. Next slide. Adjuvant systemic therapy refers to treatment, again, to treat the whole rest of the body. And the goal of this is to eradicate any microscopic cancer cells left behind, including the breast or anywhere else in the body. The goal is to maximize probability of cure, and so it's given with curative intent. And this is because once cancer cells have escaped and have traveled somewhere else, farther from the breast and the local lymph nodes, that is considered metastatic disease, and metastatic breast cancer is considered incurable. Treatment options differ depending on stage and type of breast cancer, but it's important to try to balance risk and benefit of each therapy because the amount of risk and benefit can differ depending on what the type and of breast cancer that you have, as well as the type of therapy that's being recommended. Next slide. So breast cancers are most commonly divided up based on their receptor status. So the three main receptors that we look at are the estrogen and the progesterone receptors, which are our hormonal receptors, and the HER2 receptor, which is another breast cancer that can, which is another receptor that can sometimes be a driver of certain types of breast cancer. So if you have an estrogen and a progesterone or a progesterone receptor that is positive, then you are hormonally driven. And these hormone positive breast cancers are the most common type of breast cancer, making up, nearly kind of 3/4 of all cases. HER2 positive and triple negative breast cancers are significantly less common, and they're considered the more aggressive type. HER2 positive breast cancers have that HER2 receptor that's positive, and a triple negative breast cancer means that each of those three receptors are not present. Okay, next slide. So hormone positive breast cancers are the most common type of breast cancers we talked about early on the slide before. And these are cancers that are hormonally driven tumors. Compared to the other types of breast cancers, these are typically considered more indolent, well-behaving types of treatment. And most of these tumors are going to benefit from adjuvant endocrine therapy or treatments that block estrogen in the body. These are usually pills such as tamoxifen, anastrozole, letrozole, exemestane that you take for at least 5 years. And these are medications that are recommended for nearly all women with hormone-positive breast cancer because they have been shown to have benefit in reducing risk of recurrence and metastatic recurrence, as well as helping women to live longer and improving survival. Only some of these hormone-positive breast cancers will require chemotherapy. And this is usually dependent on whether you're in menopause or not, your staging, so whether you have lymph nodes or not, and whether you have a kind of additional higher risk markers or not. Next slide. So HER2 positive breast cancers are a less common type of breast cancers, and these are characterized by an overexpression of that HER2 receptor that leads to excessive cellular division and kind of drives that cancer. HER2 positive breast cancers are biologically aggressive types of breast cancer with poor prognosis and shorter overall survival. But this was before the adoption of anti-HER2 therapy. So within the last few decades, I'd say within the last 20 plus years, new therapies have been developed that specifically target that HER2 receptor that's overexpressed in these types of cancers. And these are antibody-based therapies. So these are things like trastuzumab, which is commonly known as Herceptin. These are antibodies that specifically target that overexpression and kind of give more directed therapy for these treatment. And the discovery of these types of therapies have significantly improved prognosis and survival for these patients. These are types of patients whose treatment is going to involve some sort of chemotherapy regimen, along with these HER2 antibodies for at least an entire year. So the chemotherapy is usually about 3 or 4 months, and then the antibodies for an entire year. Okay, next slide. Triple negative breast cancers are another uncommon type of breast cancer that are biologically more aggressive with poor prognosis compared to the other subtypes. Like we talked about before, these are tumors that are characterized by a lack of the estrogen, progesterone, or HER2 receptors. Therefore, therapies that target these receptors, like the hormonal therapies or those HER2 antibodies, are not effective. Therefore, the kind of hallmark or kind of the mainstay of treatment for these types of breast cancers involve chemotherapy. So the majority of women, so nearly all women, are going to receive some sort of combination regimen for chemotherapy for at least 3 to 4 months. There are people that are considered to be higher risk, and this usually is dependent on tumor size and lymph node involvement, that we know are at an even higher risk of recurrence with poor prognosis. Immunotherapy is something that has been discovered in the recent years and has been shown to be a very effective treatment for triple negative type of breast cancers. Immunotherapy is a new type of therapy that is different than chemotherapy or these targeted antibody types of therapy. They are therapies that are designed to kind of use your own immune system to be able to attack the cancer. So it's treatments that are antibodies that are kind of retraining your immune system to also fight the cancer. So the most common, or the one that we use for breast cancer treatment, is something called pembrolizumab, otherwise known as Keytruda. And this is a treatment that we add on for an entire year, in addition to chemotherapy for those at high risk. Next slide. So kind of in conclusion, mortality from breast cancer has decreased in US since the 1990s, despite increased incidence. And this is attributed to some of the things we talked about today: early detection, screening measures, identifying people with high risk, augmenting and increasing kind of screening modalities for people that need it, but depending on risk factors and history, and improvement in systemic therapies that we've had. Our challenge of the future is to improve therapies for kind of advanced diseases, because as much as we discover and improve, there's always room for improvement, and to develop even less toxic therapies and de-escalate treatments when we don't need them, and to prevent the development of cancer in those with high-risk individuals. All right, next slide. And I think that's the conclusion. Okay, so on behalf of everyone speaking today, we'd like to thank everybody for being present, for giving us the time to kind of speak and bring awareness to both what Memorial Sloan Kettering at Monmouth has to offer, and hopefully teach a little bit about breast cancer and what we can do for breast cancer screening kind of in our community.
Thank you so much, Dr. Wong, Dr. Boleyn, and Dr. Park. You are all a wealth of knowledge and information. Thank you so much for doing this with us. And of course, Barbara, to you too, for coordinating these 3 wonderful docs to come do this with us. I would first just like to open it up and ask if anybody here has any questions. You can feel free to unmute yourself and ask directly, and or feel free to put it into the chat box if you are more comfortable doing that as well. And I too have some questions that I was jotting down, but I'll leave the floor open for the participants first. Okay. All right, hearing none, I'm gonna go ahead and ask a few myself. So in one of the first opener slides, Dr. Wong, you had mentioned about the supportive services additionally that MSK Monmouth offers. And I was wondering what you may offer in terms of survivorship, specifically around the self-management course, Cancer Thriving and Surviving. Wondering if that's something that MSK has offered in the past or currently offers now.
Thanks for your question. Yeah, so survivorship is certainly a big part of what we do, and it's an important part of the cancer journey. And fortunately, as our therapies have increased, we've improved survival, and we have now end up with a large population of cancer survivors who have their own unique needs. We do have survivorship programs, and they tend to be disease specific. So, for example, a breast cancer survivorship program would be very different from, pediatric survivorship, different from, gynecologic cancer survivorship. And these are programs which really focus on number one, monitoring and surveillance. Number two, dealing with sometimes some long-term consequences of our treatment. While our treatments are very effective against the cancer, we do understand that unfortunately there's no treatment that comes with zero toxicities, and there can be long-term toxicities. For example, premature menopause sometimes happens from treatment, and the downstream consequences of putting a woman's body into early menopause, osteoporosis, cardiovascular health as well, nutrition, exercise, and getting back to baseline. So our survivorship providers do talk, they spend the time allotted during their visit rather than talking about treatment, because that's over talking about getting back to baseline, monitoring general health issues that may come up. And then just general education as well about new discoveries that might be pertinent to that person. Also, the psychosocial component of being a cancer survivor. We found that as patients are going through treatment, they're in one frame of mind, kind of in a survival mode. But many times after the treatment has been completed is when they have time to sit back and process things. And it can be emotionally and mentally quite difficult. So we offer a lot of different supportive services to help with that as well. So it's really just you're looking at the entire person and providing care along the entire spectrum.
Yes, no, and thank you for your answer. I was hoping you would talk about the importance of like individual supportive services. So our coalition is working on something with oncology teams and primary care teams as with survivors, of course, in the loop about the use of survivorship care plans. I know that's somewhat of a thing of the past. Some people use them, some don't. But the importance of using an individualized after treatment plan where communication takes place with patient, oncology team, and primary care team is something that we've heard from patients that's very, very important to them. So just kind of hearing that you feel it's individualized and that you're working with them even long after the treatment has stopped is hopeful. And if you'd like to do more in that arena with us with the primary care teams, please let us know. We'd love to discuss that collaborative endeavor.
We'd be happy to do so. Absolutely.
Great. Great, thank you. One other question that I had was for services, additional supportive services that maybe for people who don't necessarily identify as a man or a woman. So our agency is really raising awareness on the use of people that are identifying with different pronouns. And so are there any programs, supportive services for someone who may not come to you and say, I identify as a woman, I have breasts and I have a concern. But instead say, I identify as they or them or he or him have breasts and have a concern.
Yeah, that's a great question. Thanks for bringing that up. So our institution is acutely aware of, that there is a certain group of patients who are non-binary and who often have difficulty or feel, a certain stigma when seeking healthcare. And we do have a group of providers who are, what we all do and are very open to providing care for these individuals, but there is a particular group within MSK with a specific focus on taking care of the physical as well as psychosocial needs of this population. We're still in I would say research still needs to be done with respect to how, for example, transgender individuals will respond to the various treatments, because there has just been, unfortunately, a dearth of research because of the relatively small numbers in the past. But understanding, especially, for example, in a disease like breast cancer, which is so hormonally driven, how individuals who have gone through gender surgery respond to different hormonal manipulations and the type of prognosis and the type of treatment. So very much an ongoing interest at our institution, and definitely a lot of support for those individuals.
Excellent. We often get people that are coming to us in need of services. We help navigate them. So to be able to have this knowledge, like MSK does have support services for this group of people is helpful for us. Thank you for saying that. And I do have one more question, but I'm going to ask if anybody else who's here has a question that may have come up in the meantime. Please feel free to ask now. Take yourself off mute or write into the chat. Okay, hearing and seeing none, I'm going to go again. So, Dr. Park, you had mentioned during your talk about the importance of limited or, non-use of alcohol, as well as, certain diet to help reduce your risk of breast cancer and other cancers. So, we hear, Dr. Google talks to us about sugar intake, gluten intake, and people with higher risk or have the diagnosis of cancer. In your opinion or experience, what have you seen around sugar and gluten as it relates to cancer? Is that something that there's a link there that we should be, you know, omitting sugar or gluten from our diet to reduce the risk?
And I think, and I try to preface the part about diet to say that we really don't have a lot of good quality data about diet. And it's one of the things that we can do to help kind of reduce, but it's probably one that we've got the least concrete amount of evidence to kind of say, this is what you should be doing because it leads to this amount of improvement. Um, the the in general, I would say that, lower sugar kind of, a lot of these things don't exist. And the problem with why diet is so hard to kind of look at is because they don't necessarily, exist in a vacuum, some of these things kind of all go along with the generally healthier diet and lower body fat, and kind of go with a lot of these types of things. So I would say lower sugar is good. There's nothing to say that X amount of sugar consumption increases your risk of breast cancer by this much. Same with gluten or carbs and things of that sort. Other than saying generally kind of trying to reduce and kind of have a lower sugar intake, I generally don't tell people they have to cut it out completely, or same with gluten or anything like that, because we just don't have enough evidence.
Okay. All right. Thank you. Thank you for that. And I'm going to check the chat box one last time. See if there are any questions that came through. Oh, we did have somebody with a request to share the slides. And so I was wondering if that would be okay from the three docs perspective. And Barbara, are you all okay with that?
Yes, absolutely.
That's fine.
Okay, I'll transfer it to a PDF before I do that, just in case there are any notes, sensitive notes there. Okay, so just once again, thank you all for your talks and the education that you provided to us. Barbara, once again, thank you to you for coordinating this whole thing with us. As I mentioned in the beginning, we do this once a month. It's part of a larger series called Our Health to Hold. Next month, we will be focusing on lung cancer awareness, and we have our friends at Tobacco Free for a Healthy NJ that will be presenting with us. So we look forward to having you back with us on November 27th at 10 a.m. And just thank you, everybody, for this information. Karen and Mariella are also thanking you on the chat. So thanks, everybody, and have a wonderful day. This is the conclusion of our program. Bye-bye.
Thanks for having us.
Thank you.